So first, I will invite Dr. Minu MATHEN, the most sought after speaker in AIOS. So this is his last session, last talk in this whole conference.
Thank you, Mahesh, President KSOS, and dear friends. Thanks to AOS for this opportunity. And my presentation is on different techniques on phaco in different grades of posterior polar cataract. So, generally, we get soft cases like this. So, femto phaco is a very good tool if you have access, because the rexus is done for sure. So rexus is very important. If you have the PC opening up, then we can place the lens on the rexus, and if it is centered well and sized properly, like in a femto case, you can always capture the lens also. And doing nucleotomy in a cylindrical fashion, that is very useful in this femto phaco, so that you can aspirate off the center without any hydrodissection. The nucleus comes off. So no hydro procedure is required. We just have to go in a spiral fashion and aspirate the pre-cut nucleus in the center. So towards the after that, there is thick epinucleus remaining. So either it can be mechanically separated using a blunt tip chopper, or it can be visco-dissected and then gradually pulled from equator all the sides. See, now I can see that the polar cataract is off and there is no PC rupture. So then I can proceed, but then always have it in mind that it's a very weak area and a thin area, and it should not be handled roughly like a regular posterior capsule. Be very careful and gentle with the central part of the posterior capsule in all posterior polar cataracts. And once that is done, do not shallow the chamber, it's very crucial. Place viscoelastic before you remove your handpiece, and then cortex aspiration again from the equator first, and finish off the equatorial part and come to the center, because during IA, if the PC opens, most of the peripheral cortex is aspirated if you come to the central part at the end, and an IOL can be placed into the bag. And also, at the end, hydration, it should be done gently and carefully. Do not hyperinflate. This is a posterior polar with an open PC. You can see the end-to-end opening of the posterior capsule. So sizing and centration of the rexus is very, very important. 5 millimeter or less than that. I am doing no hydro procedure. This is my 2 millimeter long blunt tip chopper, and this is the technique which I follow now in all the cases. I go spirally around the nucleus. This is called the coring technique. I go around the nucleus. The epinucleus is taken out with minimal vacuum and adequate energy to take out the nucleus, and the bent Kelman tip is enough for this. I have realized you don't need a special tip for that. So when the red glow brightens, it means that you have gone deep enough, and then if you can easily pick up the nucleus from the center. And now you have the thick epinucleus left. See the manual separation of the epinucleus from close to the equator. This is using the 2 millimeter long blunt tip chopper, and then one area which is opposite to your incision can be freed once, and once the equator is freed in one area, there is more space and room, and we can continue using this for the temporal 180 degrees, and after that you can replace viscoelastic in the anterior chamber before removing, if you want to remove. But then I'm continuing without doing that. The second instrument can be taken out. This is picking out the epinucleus out. There is no rotation happening. This is going towards the equator and picking it up from different directions. If it is difficult for a surgeon, you can stop, put in viscoelastic, go in through another paracentesis and mechanically remove the nucleus from different angles. But the two paracentesis on both sides and the main incision will be enough to mobilize the whole of it. And luckily, the PC rent has not extended, and always put in viscoelastic before exchanging instruments. And aspiration rate has to be very low. That is very, very important. In IA also, if you have aspiration rate very high, you can pull on to the vitreous which is not yet disturbed, the anterivitreous phase, and cortex can be aspirated while exchanging hands also. Please do fill in viscoelastic like this, and then take out the irrigation and aspirate from the equator, bring it up, and bring it into an area where there is no, the PC is intact, and aspirate very gently. Use the irrigation, very important, should not be facing the open PC. It should be facing the equator, the angle, or above the iris plane, so that there is no turbulence into the open posterior capsule area. Once that is finished, we can again put in sodium hyaluronate for IOL placement, because there is no extension onto the side, because it is like a two pillars, you can see this. So in posterior polar it's like that. So if we open up the bag and there is no vitreous disturbance, you can always place a single piece lens into the bag. But nowadays I prefer 3-piece lenses in the sulcus, and the central sized rexus can always be used to capture the IOL into the capsular rexus margin. Be very gentle in placing this. Once you have a capsule rexus tear, then it is difficult to place even these lenses. So please be careful about injecting 3-piece lenses, the multi-piece lenses, and aspirate as much as possible by irrigating from behind the IOL. Don't go too much underneath the IOL. You can always leave a little bit of sodium hyaluronate behind. It doesn't cause IOP rise or inflammation. And at the end, you can try to capture the optic in the rexus margin if your sizing is right. If it is too big, you can leave it in the sulcus also, doesn't matter. So this is how after the capture, optic capture, these two haptics are out. So this is the third one where the nucleus is hard with the posterior polar cataract. So here there is no hydrodissection done. The central debulking of the nucleus is done, and the chopping is done towards my left. Here it's a sharp tip chopper which is being used, and towards my right one more chop. So you get 1 pi, which is almost 1/8 of the nucleus, and that can be removed. Once that is removed, you turn the tip towards the left and make 1 more pi. So again 20% of the nucleus comes out. Then turn towards the right, and then make 1 more chop. So this is the way you can disassemble a nucleus which is hard without any nucleus rotation. So now I take out my chopper and bring in the other side of my chopper, which is blunt tipped. So that is moved across along the equator, and then I create a cross chop and support the nucleus with the phaco probe and chop again. And you create another pass along the equator and support it like this and lift up. Now half of the bag is empty. There is a lot of space, and this lens can be picked up from the bag and lifted. There is no rotation. It is just picking up and freeing the nucleus from the bag and lifting out. So this is just a lift out rather than rotate. The shearing force of rotation of the nucleus epinucleus complex is that which causes the even unopened posterior capsule to open up, because you shear out the posterior capsule which is weak, and then this nucleus is brought into the pupillary area and is emulsified completely. Now you can notice after the nucleus is gone, the central thick posterior polar cataract is still there. This is called viscodissection. So we can go to the equator, decompress the anterior chamber a little bit, and then we inject visco at the equator. So we create potential space between the equatorial epinucleus and the capsular bag, and you can additionally use your blunt tip chopper to mechanically move the epinucleus from the different areas of the equator and then move it free. So go to the equator and start aspirating, and by some time you will realize that the polar cataract has come off and there is no opening. And if there is an opening, we know how to deal with it like I did in the previous case. So the epinucleus is gradually taken out with the phaco probe. Once the epinucleus is gone, change over to IA and then very slowly aspirate. It will take some time because they are thicker epinucleus bits, and then don't irrigate on the center of the posterior capsule. So this is a classical posterior polar cataract, and then we managed to take out the whole thing without an opening. But then the plaque which is there on the posterior capsule is very thick. It is difficult to leave it like that, and patient vision may not be that very great. If we can try to peel it off, but almost never it comes off, and it will come off only with the posterior capsule. It will be adherent to that. So we can, like we do in pediatric cataracts, we can do a posterior capsule rexus here, identify one area where you have lifted it up, and then turn your tip towards the side and then hold it and include the central area. And I'm trying to peel it off, it doesn't happen. So make a small nick somewhere wherever you can, and then go include this one also. So I have made a nick here, and then including this plaque, we can do a central posterior capsule rexus. And then this, if you put in sodium hyaluronate, little bit of sodium hyaluronate in the anterior vitreous face, you will be able to catch only the capsule and do a clean central 3 mm opening, so that you can place the IOL, single piece IOL into the bag itself. I now am always for 3-piece IOLs. If I don't promise for this posterior polar cataract toric IOLs or multifocal IOLs, because anytime anything can happen, so no promise of any premium IOL. So I go into the sulcus and then capture it, and it's a very stable positioning of 3-piece IOL into the sulcus and capturing it into the rexus margin. And aspirating behind it is not that very easy to avoid vitreous prolapse. You will get vitreous. So if you want to take off all the visco which has gone behind, you can always do a little bit of vitrectomy along with aspirating. You can complete. Now I'm going with the vitrector and completing the aspiration of the visco along with the anterior vitreous phase, and maintain irrigation. Now with the irrigating aspirating probe, we can gently tap the margin of the equator underneath the rexus margin so that it is captured very well and the lens is very much centered. Because many times the sulcus is different in size. You know, in some location the 3-piece lens will be more centered, some location it will be decentered little bit. So it is always good to capture in a rexus margin whenever you put a lens into the sulcus. And thank you very much.
Thank you, Minu.
Any comments?
Yeah. Just one doubt regarding the last video. Is it always advisable to do the posterior capsular rexus? You can do a eye capsulotomy later also.
Yes, that is very much possible. Only thing is, when it is so thick that post-operatively also vision is going to be very low and patient is not going to accept, and if you want. So always it's up to the convenience and the expertise of the surgeon. If you feel that you're going to damage more, you're not able to get a posterior capsular rexus, you won't be able to place the IOL properly, don't do. You can always tell the patient, because nowadays for other non-posterior polar cataracts also, I'm telling patients, showing the picture that the posterior plaque is thick and it may be extending onto your posterior capsule, and vision may not be complete, it may be subnormal. You will need a yak capsule later. This cannot be taken out during phaco. I tell all thick posterior subcapsular cataracts also.
See, some of the silicone oil related cataract also, they have this plaque, no, in the posterior pole.
Posterior pole.
Sometimes they
But
may be
many
able
of
to
them
peel.
come off very easily.
They
Many
may
of them
peel.
can be peeled off. If you slowly try to, with a blunt dissection, if you try to identify the plane, it will come off. But some are behind the posterior capsule.
Yes.
Some are behind the posterior capsule, it will never happen. We'll have to cut it with, but I place the lens and ask them to cut it with the vitrector and take it off. So that's what happens with silicone oil. So always the VR people will cut it off with this with the vitrector and clear that off.
Thank you, Minu.